Good morning. Welcome all of you for this important quality circle. May I request Dr. Maggie to start this meeting with a word of prayer.
Let us bow down our heads in prayer. Our Heavenly Father, thank you for this wonderful day, Lord. Thank you for bringing us together here as we celebrate our 125th year of this institution. We thank you for all the mercy and blessings that you have showered upon us. Thank you for bringing each one of us here safely. Thank you for choosing us to be an instrument in your healing ministry. Guide us throughout and help us to carry the legacy of our founder, Aunt Ida. We ask this in the name of our precious Lord Jesus. Amen.
Greetings to all of you. A special welcome for this heritage lecture by the Department of Pediatrics today. A special welcome to all our senior faculty members, those are able to attend this special meeting today. It's a time for us to thank God for His blessings and guidance to develop this department through a lot of milestones, expansions. And it's not only that, it's a time to think about the fruit of our hard work, the fruit of our perseverance, and the fruit of our diligence work. So it's basically a good thing for all the upcoming pediatricians to listen to how it was guided by our senior people in this particular field. With that introduction, I would like to hand over to Dr. Kala to moderate this session.
Good morning. So the journey of child health cannot be encompassed in one telling. There is no way we could include every event, every person who helped shape the department to what it is today. But today we have an exceptional speaker, Professor Dr. Raghupathy. He is a multifaceted personality with multiple achievements. Pediatrician to begin with, having undergone his PG training in the department and passed out with, I think he's a gold medalist from the Madras University in 75 to 76. I think the record is still to be beaten. Later, a pediatric endocrinologist of world renown. He was awarded the International Outstanding Clinical Award by the European Society of Pediatric Endocrinology. He's most respected by all of us, but also to some extent feared, but much loved. Today, most importantly, he's a great storyteller. So we used to love his, during the busy OPD, the 10 minutes, quickly we'll come into his room just to hear one or two story or one or two jokes that he was always tell some inspiring stories. So we are extremely grateful that you're here with us, having traveled from Bangalore today.
Good morning, my dear friends. Welcome on a misty morning of Vellore. I feel as if I'm in Bangalore still, and it is so cool and nice. Nice to have a change of weather. Every time I come to Vellore, I feel like running back the same day. Though I was born here and brought up here and lived here so long. I don't know whether you know, I was born in this hospital. And I'm a true son of the soil. And many of you may be staff children who were born here, but you had no other choice. Whereas I chose to be born here, or my grandfather made me to take birth in this place. Anyway, I had to present 100 or 1.25 century of pediatrics in a time capsule. I don't think I'll waste time, and I will start off straight away with my slides. You all know Dr. Ida Skada was a multifaceted person, and she was pressed with so many needs. The other day I heard that she even did ENT surgery. And so she was not only an obstetrician, and she did many other things, was a physician and was a surgeon. And do you think she would have left off pediatrics? I'm sure she was doing pediatrics also. And she had a home for children in this hospital, especially for the destitute children left unwanted in the hospital. She created a home for them and even arranged adoptions for them, whenever possible. And she had a love for children also. It was not only women that she cared for, she was also looking at pediatrics. And I think, to my knowledge, pediatric service in India commenced at Vellore in 1906 with a fully qualified pediatrician. Okay, not just Professor Skada. And this was initiated, I'll come to that in a minute. But if you Google the first pediatrician in India, you will find all these names. 1928 onwards. Even earlier, we had, pediatric service established by Dr. Ida Skada. And by 1928, we had a hospital, children's hospital in this place. I move the slides here. Okay. Even in the words of her beloved niece, praising Aunt Ida, she mentioned that children were flocking to Dr. Ida Skada in the roadside clinic. They always came with flowers because she loved flowers. And she always gave some cards to the children. So the pediatric service was started much, much earlier. And when I say 1906, my statement is always challenged. And I'm also not able to prove when the first pediatrician trained in US came to Vellore. I'm not able to prove that date, but I managed to fish out a letter written by the first pediatrician, Dr. Anna Degenering, and from the net. And you can see that this is dated 1920, and she must have been here earlier. This letter is an appeal. You can see her signature, and this is an appeal for her other colleagues in US, more for recognition of this medical school and also for help by sending somebody else, because she was overwhelmed with the pediatric service. And that is Dr. Anna Degenering, the first pediatrician in CMC Vellore. And but you can see the people are claiming everything. And I told you already that, sorry, this is the children's hospital which was established in 1928, as early as that. And subsequently, Dr. Anna Degenering was doing a lot of work. She was teaching the preventive aspects of pediatrics to all the medical students who were admitted there in the school that was started by Dr. Ida. And subsequently, Dr. M.D. Graham joined the department. And she set up a neonatal service for the first time. And this is one of her papers. And you can see that she described the first case of hyaline membrane disease in India. And so people were not just offering services, but they were also academically interested, building up the department and so on. And this lady was subsequently followed by Professor John Webb. And he was J.K.G. Webb, and his full name is there. And this is a picture with his wife. And the other one is at the time of his leaving Vellore. He is along with the next director, Dr. L.B.M. Joseph. And Dr. Webb came here in 1953 and spent a whole of 18 years in CMC Vellore, and he was an arduous and meticulous clinician with great attention to details. And he was relentless in spite of all that work. He was relentless in providing the best possible childcare. He was a great teacher, and I am told his rounds used to last 8 to 10 hours. And everybody used to talk about it when I came here. And by the way, when I joined much later as a senior house surgeon, I used to stand at the gates of the child health department, and I used to wonder whether I shall ever get an entry into this place. And God has been very kind and great. And I was not only given an entry, but I was trained here, and I was also given an opportunity to serve the children, and grew in the department as a staff member, became head of the department. And also I'm here today to recapitulate all the history of the CMC, even after my retirement 20 years ago. And so Dr. Webb was the only qualified pediatrician in the department at that time. And he had an enormous clinical workload, but he found time for academics and pediatric research. And he has published so many papers, and he had achieved multiple landmarks in pediatrics. And by the way, he was also a professional cricketer. And he was really multifaceted. And some of the things that caught my eye, I want to highlight here. The first oral rehydration solution was devised by him long before the actual ORS came in. And he called it oral NACS, sodium, potassium, and sucrose. Okay. And those were the ingredients. And he emphasized the importance of hydration more than antibiotics. And for mild and moderate dehydration, he said that was the important aspect of treatment, and not antibiotics. And you all must be knowing that only 30% of diarrheal cases you will have a bacterial etiology. The rest were not. And subsequently, I'll tell you what else was found. And this ORT was a pioneering device which he used. And this is the forerunner of the later OR therapy. And this OR therapy, you know, has been acclaimed as the greatest medical advance of the century in the Lancet. And Dr. Webb also used growth charts at that time. As an endocrinologist, I'm very much interested in the growth charts. When I came here, there was no growth charts. We had to build up our own. And he had already done that earlier. And the concept is very important. What was his concept? Growth monitoring. That was his concept. And that is a very essential part of growth in children. And he had done that. And it was not statistically approved kind of growth chart, but the concept, as I said, is important. And he used well-nourished staff children as the role model, and rural and urban data also he picked up, and he had only 3 lines. But as you all know, growth chart, which growth chart is not important. It's the same growth chart that you have to do for following up the growth and to see whether somebody is doing well or not. This was started by him. He also was emphasizing the role of RH blood grouping in those days. And you know how important that is. His untiring research work led to the isolation of Japanese encephalitis here in Vellore for the first time in India. Okay. And he was also able to, the virus was isolated from the mosquito, and the vector was also identified as Culex vishnui. And this was a real landmark, and he did it along with the Viral Research Center in Pune at that time. And to quote the literature, a passage from the literature, the discovery or the isolation of the Japanese encephalitis virus was a shot in the arm for the Viral Research Center, because till then they had not found anything at all. And this was the first one. And it was such an important aspect or landmark. And this was of interest to Rockefeller Foundation also. And he went on with his viral research work. So many other viruses were also isolated. And he set up even a field virus lab in the community. And his work did not end with just getting the virus. He was applying all the clinical data and made criteria for diagnosis of viral encephalitis. As a trainee in the department, I know we used his criteria to differentiate from typhoid encephalopathy, for example, and what is a bacterial infection and what is a viral infection. So he was very astute clinician also. And you must be knowing about this. Tropical pulmonary eosinophilia was a mysterious illness. And the etiology was obscure till then. And he solved the problem. And he, with the help of Dr. C.K. Job in pathology, they used to sit and do dissection microscope, and they will be teasing the tissues which were removed from the affected children, lymph nodes, liver, and so on. And he proved that it was a microfilaria which was causing this problem. And again, he had clinical criteria for diagnosis. Absolute eosinophil count more than 4,000 per cubic millimeter, you can make a diagnosis. You don't have to do this dissection work all the time. And so he did quite a lot of research, and his research on childhood nutrition and viral infections later on was continued by Professor Sheila Pereira as a full-fledged nutrition research unit, and Professor Jacob John, who is here, as a full-fledged viral research unit. These were the beginnings of all these departments which grew later. And he was also the president of IAP in India, and he was appointed director in 1967. And during his tenure, the Q block was opened. The pediatric wards were modeled on the same lines as the British pediatric wards. And it was such a different scene altogether. Having worked there, we know how well equipped the wards were. And he had also included pediatric surgery, cardiology, and infectious disease in that same ward. And it was an envy for the rest of the hospital. And when we were about to leave, there was such a clamor, who should occupy those areas? Okay. And he also named the department, renamed the department as Department of Child Health to emphasize the importance of the positive aspects. We are not treating only pediatric diseases, but we are looking at the positive health also. So he called it child health, okay, pediatrics. And I now find that it has gone back to pediatrics, but I think it is still a division of child health, okay. And holistic care was given to these children in the way of well baby clinics, immunization, promotion of breastfeeding, and so on. And with the passion for his work, dedication, and devotion, he had learned to speak Tamil also after spending such a long time. And when the Q block was inaugurated, and he was the director at that time, and he gave a public speech in fluent Tamil in the presence of Dr. Karunanidhi, Chief Minister of Tamil Nadu, and he is a well-known Tamil scholar. I was fortunate to listen to that speech because I had just joined CMC as a senior house officer, And I was really impressed, being a Tamilian myself. I was impressed with the fluent Tamil Professor Webb spoke. And that's in the presence of Dr. Karunanidhi and Dr. Webb. He trained and inspired the next generation of pediatricians, started PG courses for the first time. And so far, we must be knowing that DCH, we have trained 1,958. It was started, and total of 385 DCHs and 252 MDs have qualified from our department. And many of them have gained acclaim for their own notable and outstanding research in several areas of pediatrics. After 18 years of service, Professor John Webb returned to UK, and he was awarded the OBE award during the Queen's birthday honors. And there the first batch of MDs, Dr. Ramanand Kamath, who is here, and unfortunately the other person could not complete the course. So he was the first MD student from CMC Vellore. And he was followed by Professor Malati Jadhav after he left. And she joined CMC in 1957, and she was trained in Grant Medical College by Dr. Coelho, George Coelho himself, who was a great pioneer in pediatrics in India. When I showed you all the names of the first pediatricians, they were all Indians. Perhaps that's why they don't count MD Graham or Dr. Anna DeGenering as the first pediatricians. And Dr. Malati Jadhav, after spending some time in the UK, she came here and started the neonatal unit and upgraded it. And these were the pre-ventilated years. And I have always proudly acknowledged that the mortality rate in that primitive department was only 2%. How did we manage without ventilators and all? Dr. Malati always used to say we had human monitors. And it was the hard work of all the pediatric trainees which helped in improving the mortality rates in the newborn babies. She also was the first one to establish the normal bilirubin value, and unnecessarily they were all being branded as going towards chronic risk. But she said the bilirubin value in the newborn, if it is a term baby, it is higher, and for a low birth weight, it will be different. So that was the first point she established. And there is Professor Malati Jadhav with her tender, loving care. And she was also known for a publication of vitamin B12 deficiency syndrome. And this paper was in the Lancet, and this was recognized, especially in vegetarian mothers. And you can see this original paper I have shown here. She also upgraded the nursery to level 2. And she was involved in ICMR study on diarrheal diseases in infants and children. And that was a major project which gave us quite a lot of clinical clues. And she was a very hard taskmaster, and she was renowned for that. And I used to say, somebody had to cry during her rounds, and only then she'll be happy. And but at the end, we learned so many good things from her. The basics were drilled into us, And she was a very great teacher, and she was a totally different person when she invited us home. She was very generous, and she was such a pleasant hostess and made sure where we sit and what we eat and so on. And even for the trainees, and if somebody got unwell, she will make somebody else go find out the situation and come back and report to her. And early morning, 6 o'clock, reporting on the telephone was also a routine. So many of those things which we learned to maintain the standard in the department. And Professor Sheila Pereira was there earlier, but she was in nutrition research, and she joined the department as a head of the department in 1975. She was always there. She was also interested in the viral research and so on. And I cannot give you a better picture than this to give you an idea of the personality she was. And she was always lively, very lively. And somebody has even commented, "You're so jovial and you are so happy. Do you do any serious business in the department?" But it kept our morale very, very high, you know. And the coffee time in the department was the time to relax and to add new energy, rejuvenate ourselves, and so on. And she joined Webb as a registrar. And I told you about the viral encephalitis disease. And there was an invitation for investigate Kyasanur forest disease, which was a very fatal illness, and nobody went to do that kind of research. But she was a very brave lady, and she did go. And I am told of the team that was working in Shimoga district, Kyasanur forest disease, she was the only survivor. And she came back with a lot of information on this disease. And she acquired her MRCP. She left CMC for a while and went to UK, trained, and came back. And when she came back, she started the nutrition research unit, and she's done a monumental work on protein energy malnutrition. And we had a Kwashiorkor ward, a W ward, and we were all posted there to learn about malnutrition and so on. This project was funded by PL 480 funds for 18 years. And you can imagine the quality of research that she produced. And she emphasized that 2 gram protein, 2 gram per kilo protein per day is more than enough. When the teaching was at least 10 grams or something like that, she's proved that it was not really required. And milk was very important. At least 100 ml milk should be given in the rehabilitation process. And she was also a member of the principal member of the Vitamin A International Society, International Nutrition Society, and so on, and was a WHO consultant for international nutrition research. And she will disappear sometime. And a few days later, when we inquired where was she all this while, she said, she will say she had gone to Geneva. She made such frequent trips to Geneva as if it was Katpadi. And she was very much in demand. And she published so many WHO leaflets and so on. And she has done monumental work. Like, she proved that fortification of common salt with iron was no use. Otherwise, the Indian government would have spent such a lot of money and wasted it. And she proved that it was not required. And she joined the department, as I told you, in 1975. And she was a very strict disciplinarian. In spite of her jovial nature and all, she made sure that you are punctual to the dot. Okay. And she found time to relax. And her formulas for high calorie cereal milk for nutritional recovery and an inexpensive lactose-free formula for lactose intolerance are all very, very well remembered by all the trainees even till today. And many technical reports of the WHO were written by her. And she has also contributed multiple book chapters. So her motto was duty first. She was very friendly and almost maternal in her care of all the trainees, and rich nutrition. Being a nutritionist herself, we used to get all the baked cakes, and she used to bake them and bring them specially for us every now and then. We had many visitors to the department, and this is the legendary Dr. Waldo E. Nelson from Nelson's textbook of pediatrics. He himself had come in 1970 to the department, and there he is in the middle. And I actually showed this picture earlier. That is Dr. Centerwall. He is another visitor to the department who was working here as a staff. And he and his wife are geneticists from Loma Linda University. And they conducted a number of studies on consanguinity and congenital anomalies in South India. And they contributed a lot to the understanding of genetics in those days, which is very, very early days for genetics. And Dr. Jacob Yerushalmi, he's a biostatistician from California, and there he is in the picture. And he did a lot of child development and child health studies. He was always following birth weight in newborn babies. And he had classification. It's called Yerushalmi classification of birth weight, following Lubchenko's. Okay, and he improved it, and he was doing that, and he worked here in our department, and he was there for a long time, and he worked with Dr. Sundar Rao in biostatistics. And you know, Dr. Sundar Rao is the first biostatistician here in India. And these studies helped me to do Barker's hypothesis, okay? And the information was all collected at that time, and that was very useful. And Dr. Kulasekaran, my immediate senior, doing MD here, he was doing all the collection of data, and I used to help him, and that's how I came to know there is data available. And when Dr. Barker's assistant came here, and she met all the higher authorities in the hospital and college, and they told we don't have any data. And so she went to Mysore, Holsworth Memorial Hospital, and they had all the data, like Dr. Barker in those days. And then they were presenting that data, and I happened to be in the audience. And then I told this person, Dr. Caroline Fall, that we have all the data also. Why you didn't come to CMC Vellore? You're gone to a mission hospital. And she was surprised, taken aback. She came here and she saw, and all the monographs which were prepared by Dr. Sundar Rao, she saw, and she said, I feel like grabbing all of them and running away. And anyway, we were able to do the study on Barker's hypothesis here to prove the effect of low birth weight on later life or adult in health in adults. And so these are the visitors to the department. Dr. Mark Steinhoff, some of you may be knowing, he came from Johns Hopkins, and he was working here along with his wife. She worked in a rural hospital called Chad now, and she worked there as an obstetrician. And they were so ingrained in Vellore she refused to deliver her baby in the main hospital. She delivered in rural hospital. And to that extent, they had taken up the spirit of Vellore. And we had other visitors, Dr. Martin Wright of the Wright Peak Flow Meter. He had visited us also, spent some time with us. And Dr. Balu Atreya, a pediatric rheumatologist from Philadelphia, and Dr. Caroline Fall, I had already mentioned. And Dr. Centerwall, I told you, was there. And this is Dr. Mark Steiner. He worked with Professor Jacob John and helped him in so many ways. But one thing which I remembered or recollected was the simplistic approach which we all followed and were taught in the Department of Child Health. And he was doing this simple thought. If somebody misses the immunization and then come to the OPD for some minor illness, if they had missed some immunization, why can't you give it now? Use that opportunity. And he used to call it as missed opportunity. And unfortunately, he's no more. And but he was a great friend of all of us. And I had the pleasure of working with him. And here comes the rock star. And you know all about him. And if I have to talk, Dr. Kala has to arrange a full day workshop. Okay. And it's not possible to cover all his achievements. And everybody knows about him. He's an international fame. Okay. And he trained as a DCH trainee, and that's how we lay our claims to him. Okay. And he did the DCH training, DCH course in the department, and later on has been working on so many vaccine preventable diseases, polio, measles, viral encephalitis, all those blanks are, I cannot fill. So many are there until COVID, even after his retirement. And you know his contribution towards understanding and planning the treatment of COVID, the prevention of COVID, and so on. And he started the first diagnostic virology laboratory, and it has become a center for excellence in virology and a national reference center for HIV, and so on. It goes on. The most remarkable thing that he did was he proved vaccine failure of oral polio vaccine, which was acclaimed as the greatest discovery. And he said even 3 doses of oral polio vaccine is not enough to prevent polio in toto. And he emphasized the importance of pulse vaccination with 5 more doses, and also ongoing pulse immunization, which you're all aware of. And he was forerunner for global polio eradication and so on. He was also president of Indian Academy of Pediatrics. And I don't know, I put 500 publications, but it must be more. I'm reminded of Khalil Gibran, who said, "The moving finger writes, and having writ moves on." So he has never stopped writing. It goes on, even today, okay? And I really would like to follow his example, but it's too high an example to emulate. And he was also on the International Advisory Board of Lancet for 10 years. There are so many other staff members here. As I said, the time capsule cannot mention all of them. And so many staff members who have contributed to the Department of Child Health, and their area of main interest also been given here. And then we come to the next generation. Dr. P.P. Maya, he trained as a DCH and MD trainee in the department. He was my colleague and same vintage and a good friend even today. And his MD thesis was on orbivirus. That was the old name for rotavirus. And this was published in the Lancet, and he made a remarkable discovery. As I said, 30% only are bacterial diseases in causation of diarrhea, and the 70%, this was a major role, and it was possible because of the electron microscopy which is available here. And he did a very important paper. And he was also publishing another paper called Cystic Fibrosis in South India. We thought cystic fibrosis never existed. And he made a clinical diagnosis. And Dr. Malati did not like it at all. You're thinking of only rare diseases and so on. And she walked out of the rounds. And later on, it was found to be, he was found to be right. And this is a case of cystic fibrosis reported for the first time in India and so on. And there comes yours truly. And this was a paper reporting Shigella dysentery as a cause of HUS, reported for the first time. And this, I was fortunate to get it published in the British Medical Journal. And with the help of my friend and mentor, philosopher and guide, Professor Anil, I was able to get even electron microscopy done on the renal pathology, and that was also published. And another paper is an epidemic of dengue hemorrhagic fever and dengue shock syndrome for the first time in and around Vellore. And another thing is rickettsial infections in South India, how to spot the spotted fever. Okay. And as I said, simple clinical criteria, history is what is put into us all the time. And this is what helped me in making a diagnosis of purpuric rash in the palms and soles. I thought that was very unusual. And that helped me make a diagnosis of this. And my own postgraduates, when I said, do Weil-Felix reaction and went away after rounds, they were all murmuring behind. He has to do one-upmanship and so on. But it was proved that this was rickettsial fever. And after that, diagnosis became quite easy. Dr. Thomas Cherin, he's, you must be knowing, worked in WHO and recently retired. Again, the simple elicitation of respiratory rate, clinical finding, helped in making a diagnosis. And you can see that the respiratory rate is useful to differentiate upper respiratory infection from lower respiratory tract infection. And this was published in Lancet again. And he was involved in a number of research projects. And he was awarded the Ednapalli Award for contribution to research. And Dr. Chellam Krivakaran and I joined the department, took over the leadership of the department in 1987. And I had trained in pediatric endocrine services in Australia and came back. And we started a newborn screening for congenital hypothyroidism. By the way, the first pediatric specialty in CMC, Department of Child Health, was pediatric endocrinology, apart from newborn. And it was also first fully trained, fully established pediatric endocrine service in the country. And we have many others now. When I did this newborn screening in 2001 with the help of Mona Bosca, who's here, and we reported the incidence to be 1 in 1,000 live births, whereas the Western data was 1 in 4,000. And everybody was critical. Even endocrinologists were critical, and they said, I'm overdiagnosing. But it was not true. And subsequently, over the years, when other centers started doing, they have now accepted that incidence in India is quite high. This study helped me, this study was recognized abroad, and we were invited for a consensus meeting. And this is the paper of the consensus meeting. And Dr. Anna Simon and I attended this as a part of this guidelines team. And the participants were from Europe, North America, South America, Japan, Australia, Asia Pacific region, and our own Indian society. And you can see us there, and Anna is hiding in the background. And this meeting was held in Rome, and there you can see Anna and myself. Dr. Chellam Kribakaran, you must be knowing, she trained also in Australia and commenced the first pediatric hemato-oncology subspecialty in 1982. She upgraded the neonatal services from level 2 to level 3, and she was responsible for designing the pediatric wards and pediatric intensive care in the new Idaskada Centenary Center. And she also had initiated the beginnings of ICU in the Q block, and she was able to get ventilators and so on. There she is, Dr. Chellam Kribakaran, with Dr. Malati Jadhav and her colleague, Dr. Jayashree. The Department of Pediatric Nursing was also very, very important in advancing the care for pediatric group, and not only medical, but also the surgical pediatrics. And a number of them are listed here, and many more I'm not able to for want of time, and numerous other ward sisters who helped us. And the legendary Dr. Anne Sukumar is here, and she's well remembered by everybody. And our support staff, I cannot ignore them. All my research staff, the field officers and others, were willing to do the newborn screening. Otherwise, we wouldn't have achieved that at all. Okay. And our OPD staff, I cannot forget, our secretaries, Mr. Paul Raj, Srinivasan, and Victoria, and so on. And even the attenders, Kannan, listed here, Kannan. And this person taught us how to hold a small baby for the lumbar puncture. We learned it from him, and we never failed. The positioning of the child is very important. And Gunda Pidikunu sir, he used to say. And that is very true. And we learned it from him. And all the postgraduates at that time, I'm sure, will remember the way to hold a baby for lumbar puncture. And Sampath, you must be knowing, he's a man Friday, or he's a handyman. Any problems you tell him, he'll solve it for you. And I can go on talking. So I think I'll stop there. I've exceeded my time limit, I'm sorry. But as I said, we cannot do justice for everything in such a short time. And there are many, many other things which I might have omitted. Anyway, thank you for having me once again. And I'm grateful for the invitation.
After that great storytelling by Dr. Raghupathy, I'm sure we'd love to carry on with his stories. I've been tasked to talk about embracing specialization in pediatrics in CMC. Let me start by first highlighting and acknowledging some of our seniors in the Department of Child Health. They are the ones especially known to us who have sown the seeds and nurtured some of our earliest specialties. It is through the efforts of our seniors that we have a vast bouquet of pediatric specialties in CMC today. we now have 23 specialties of pediatric medical, surgical, and other clinical services in the Department of Child Health and various other departments, with more to come. I would like to thank all my colleagues in the department who have given lots of information on the incredible work that each one of them is doing today. In the time available, I will be able to give not more than a snapshot of the embryogenesis and the growth of each of these specialties. A few other disclaimers before I proceed, that for want of time and space, we will not be able to name each and every individual who has contributed in various ways for each specialty. Each specialty has a multidisciplinary team of a variety of people, and we are grateful to God for all of them who have contributed and come to each of these specialties and who work with great commitment and passion to the cause of children. I dare say that these pediatric specialties, along with general pediatrics, would together in the future come together to make one of the finest and most comprehensive academic children's hospitals in our country and in the Asian region. Going on to my own field of neonatology, as already recounted by Dr. Raghupathy, Dr. M.D. Graham and Dr. Saroj Kapoor were some of the senior pediatricians who contributed to neonatal services in CMC. And with the encouragement of Dr. Webb, Dr. Malati Jadhav improved the nursery from an observation area to the first level 2 special care nursery in South India. Thereafter, from an era where there were only human monitors, Dr. Chellam and Dr. Jayashree played important roles through the 1980s and 90s in improving and upgrading the facilities with 24 beds and bringing in the first ventilators, monitors, and incubators. I think many of the seniors would remember the old J&K nursery. Neonatology became the first independent specialty unit in the department in 1996 under the leadership of Dr. Jana. When we moved to the ISSC building in 2000, we had 60 beds. And over time, the nursery has expanded to 98 beds, not only in the ISSC building, but also in the adjacent Paul Brand building. Despite this, there are times when our bed occupancy exceeds 120%. We are able to offer tertiary and quaternary care with a range of facilities as listed here, and also nitric oxide therapy, high frequency ventilation, therapeutic hypothermia, and NIRS. We have also fabricated an indigenous incubator for transport, which we used for several years. And more recently, we developed the low-cost Mira cradle to provide whole body cooling for babies with perinatal asphyxia, which has received international recognition. From 4,000 to 5,000 babies born annually in CMC in the 70s and 80s, we now handle between 12,000 to 14,000 births a year. And as we can see, the perinatal and neonatal mortality rates have significantly decreased, with the NMR now at 3 per 1,000 live births. Also, for babies above 800 grams and about 26 weeks, the survival rate exceeds 80%. The team now comprises senior and junior faculty as DM trainees for a year, and a range of support staff, and most importantly, a big, good nursing team. Our weekly high-risk infant clinic, started several decades ago, was one of the first in the country as part of the neonatology department. To handle the increased load and improve the quality of follow-up care, we now have 2 more OP clinics running on a daily basis And as you can see, the volume of work that's going on there. Our DM program started in 2011, and 20 trainees have graduated so far. There are a number of workshops that we run every year on a regular basis, as well as a research conference. The Emergency Obstetric and Neonatal Care Program started in CMC along with OG in 2003, and this has gone on to become a national level training program. We periodically have a PREMS party for our nursery graduates, and it is encouraging and delightful to see how well they are doing 3 to 5 years down the line. Moving on to pediatric nephrology, which the specialty services commenced in 2002 when Dr. Indra returned from her overseas training. Starting with inpatient, outpatient care, by 2007, she was able to start hemodialysis with the support of the FOV and Dr. Chellam and Mesha Kripakaran. The unit has a strong collaboration with several centers, both in India and abroad, especially the UCLA. And with their support, the first pediatric renal transplant was done in the department in 2017. They have collaboration with other centers such as Atlanta Children's and Cincinnati Children's as well. And the faculty have all worked with them. You can see how, how the pediatric nephrology work has increased over the years, and a substantial body of outpatient and inpatient work. Apart from that, a lot of renal biopsies, hemodialysis, and renal transplant and CRRT being done. Infrastructure has developed over the years, and there is a good team of support staff as well. They're also involved in research and publications, and a fellowship program has been in place since 2012, and the DM program in pediatric nephrology is due to start shortly. And this is a team of fully trained pediatric nephrologists now in the department. Pediatric emergency medicine moved from the adult casualty to the ISSC building in 2003, starting with 4 beds. But of course, this we quickly ran out of space there, and beds have been steadily increased over the years. And by 2010, there were 21 beds. And Dr. Debashish, with his training overseas, was able to establish an in-house software to monitor and triage patients. And this software has been used also not only for clinical care, but also for research and quality control. Several other infrastructure changes have developed over the years. And by 2017, it has become a 30-bed facility, but lots of patients, as you're all aware, well outside the confines of the emergency department. The fellowship program also has been started, and some of the faculty are now undergoing their DM training in other centers in the country. They have a range of facilities all that are required for a good pediatric emergency department, with services to handle medical, surgical, and oncology emergencies, as well as minor trauma. Some of the special features are the triage system that they have with monitoring, as well as points of care imaging and diagnostic services. You can see this is such a busy area with more than 30,000 registrations annually, and almost double the number of procedures being done every year. All done by this group of committed staff working in the pediatric emergency. Pediatric hemato-oncology came under the ambit of Child Health 1 in 2003, and has now gone on to become a separate department. They have built up infrastructure to handle the huge patient load over the years, as well as a committed team of staff. You can see how the work has increased exponentially over the years in the outpatient service, and the daycare is no less impressive and completely chock-a-block with patients undergoing their chemotherapy. Inpatient work also has shown an exponential increase over the years, with transplant services being commenced in 2017. There's a full team of trained pediatric hemato-oncologists, and a group of support staff as well. This shows the outcome of many of the common childhood cancers that they treat, and you can see that the results are indeed very commendable. There is a fellowship program in place already, and the DRNB program is due to start this year. The unit also has collaboration with centers across the country to provide shared care for their patients closer to their homes. And they also work with several organizations in the country to provide financial support and nutritional support for the children and their families. Developmental pediatrics was started in 1997 by Dr. MC Matthews, who's here with us today, with a team of 4 people. And they have established a legacy of comprehensive and compassionate care of children with developmental disorders. And they're well recognized throughout the country and overseas for their work. There is, again, a multidisciplinary team in the department with Dr. Beena Koshi, Dr. Samuel Luman, and Dr. Srinivasa Raghavan in the team now. And you can see how the amount of work that goes on, not only medical consultations, but the volume of assessments and therapy that they do on an annual basis. Over the years, apart from the clinical work, they have also run several workshops and symposia, and the fellowship program started in 2007. In addition to their clinical work, they also do community research and follow up 3 birth cohorts related to their research projects. And they also provide vocational training for autism support workers. Pediatric intensive care, as was already mentioned, started in a small way as a 6-bed unit in the Q3 West with 2 nurses. Moving into the ISSC building, it started first in the 5th floor and then moved on to the 6th floor where it's currently located. And by 2016, there were 24 ICU HDU beds. And more recently with the Ranipet ICU, there's another 12 beds added on. And they have a full complement of all the necessary equipment for pediatric intensive care services, including hemodialysis, bedside echo, as well as ECMO since 2016. In the Ranipet campus, the ICU provides support for children who are being managed by the various specialties there, including dialysis and ECMO. Their overall admissions has steadily increased over the years, and they provide support by several modes of ventilation, high frequency ventilation, high flow nasal cannula, and non-invasive ventilation. And you can see how the survival rates are now exceed 90%. They are well renowned for their training they provide for both BLS and PALS courses, as well as the simulation training that is provided by the PICU team. And again, there's a fellowship program in place for more than a decade, and the DRNB is due to start shortly. And these are the stars of the pediatric ICU team. Pediatric infectious disease commenced in the 1980s under the leadership of Dr. Thomas Cherian, starting off just as a retroviral clinic for children and families with HIV. But over the years, a variety of diseases have been taken care of by the team, and a full-blown ID clinic has been running since 2013. The current faculty are fully trained overseas, Dr. Valsan, Dr. Vinci, and Dr. Anil. They treat infections, both community-acquired as well as hospital-acquired infections, as well as infections immunocompromised and children and families with HIV. They are also the guardians of antibiotic use among all the pediatric services to make sure that our antibiotic therapy is rational and developing guidelines, as well as they're involved in infection control activities. You can see how here again, the huge amount of work that goes on with the dip, of course, during COVID, but the volume of outpatient consultations, outpatient work and consultations provided by this team. Pediatric rheumatology started in 2006 under the guidance of Dr. Debashish Danda, And Dr. Satish had his training again in Toronto, starting with 3 outpatient days a week. They provide consultative service to a variety of disciplines, and as well as procedures and occupational therapy. This is the committed team in pediatric rheumatology, and they have, again, liaised with several other departments to provide care. They have one of the largest cohorts of pediatric rheumatic disease in India, and this shows, again, the OP work and IP work done by this group. Pediatric respiratory medicine started as an asthma clinic in 2004, but over the years, several other respiratory conditions are taken care of. They now run outpatient services 2.5 days a week, and a whole variety of specialized services are provided with a special interest in cystic fibrosis. There's now a dedicated pediatric spirometry lab, and here again we can see how the spirometry work has increased over the years, and more recently flexible bronchoscopy is also provided, as well as home-based care for children needing therapy at home. The team comprises not only the medical faculty, but an allied health team as well as nurses. And again, they have forged collaborations with several centers in India as well as overseas. Adolescent medicine was started under child health by Dr. Mona Bhaskar after her training in Canada in May 2013. And they also have an outreach program called Project Yuva. And there's a wide range of adolescent problems that they take care of in both in an outpatient basis as well as the inpatient basis, as in counseling on a wide variety of conditions that are needed for adolescent, for the adolescent. Dr. Mona and Dr. Rashmi are there in the team along with a multidisciplinary team. This again shows how their work has gradually increased over the years, including inpatient care. Outreach is very much part of their work, both in schools and in several government institutions, as well as the community at large, as well as creating awareness in the community. And they have, in collaboration with VIT, they have developed an app for interactive, for interaction with the youth to maintain their privacy and anonymity. And this is due to be launched shortly. The Well Baby Clinic, started in 1994, is one of the busiest areas of the hospital, handling more than 350 children a day. And this is probably the largest private immunization clinic in India, and probably the world also. And apart from the initial EPI vaccines that were started, over years, several other vaccines have been introduced in the Well Baby Clinic. And you can see the volume of EPI doses, as well as new vaccines that are administered yearly, exceeding 180,000 over the years. There are several vaccines that the trials were done here in CMC before they were introduced in the country. And this is again manned by a small team of committed people in the Well Baby Clinic. Pediatric gastroenterology and hepatology started in 2014 as an outpatient service, then went on to provide, do procedures, and more recently, inpatient admissions under their own service. There were a huge number, a variety of procedures done by the team. And you can see how there's, again, exponential growth in the last few years by the pediatric gastroenterologists and hepatologists, and the huge increase in procedures as well as inpatient admissions. This is done by a small team of 3 people who are, again, trained in this discipline with the support of the adult department of gastroenterology and hepatology. Pediatric immunology is the newest kid on the block after Dr. Satish, returned from his DM training in PGI, and they take care of children with primary inborn errors of immunity and dysregulation, and making diagnostic and providing intervention as well. And you can see that they have made a promising start. Thank you.
Okay, with over 400 publications in the past 4 years, it is impossible to talk about all of pediatric research. What I'm going to actually focus on is what has exactly what the logo says there, transformed lives. And I must apologize to my colleagues for not being able to put in even, all of those that have transformed lives. So these are the firsts, and you heard Dr. Raghupathy speak about this, and this actually is, I'm indebted to Dr. Jacob John and Dr. Thomas Cherian, basically, for these details: JE virus, mumps, rotavirus, high-calorie cereal milk reversing, kwashiorkor, the first report of Rye syndrome in India, chikungunya virus isolation. And these are Dr. Jacob John's seminal articles on the immune response to injectable polio vaccine way before it came into the national program. In addition, intradermal polio vaccine as well. This is his article on the evidence of antibody response to measles immunization, and this actually paved the way for starting measles vaccine in this country at 9 months of age rather than at 1 year of age. And you heard Dr. Raghupathy also speak about Dr. Cherian's respiratory rate cutoffs, which have formed the basis of the ERI control program and have also been used during COVID by the WHO, and these are sort of standard for the country. Now, we heard Dr. Raghupathy talk about pediatric endocrinology screening for congenital hypothyroidism. I just want to actually point out, this is what newborn screening for congenital hypothyroidism can do if you diagnose them at birth. And so these are 2 children, both of them doing very well, diagnosed at birth, started on replacement at birth. And this is the disaster that you are faced with if you do not diagnose at birth. If on the left side is a child who was diagnosed after somewhere in the 2nd year, you can see that on the growth chart, he is actually, pulled up, but, he's a little behind his peers. And on the right, that growth chart, that is 11-year-old untreated congenital hypothyroidism presented last year with global developmental delay. You can see his weight is 10.5 kg. His height is 78 centimeters, somewhere around a 1 to 2 year old, and his developmental age is 2 to 3 years. Hemato-oncology actually does a lot of work, and these are some of the things that they have contributed, showing that in Philadelphia chromosome positive ALL, a good prednisolone response and negative minimal residual disease can lead to event-free survival and can be treated without BMT. And then the fact that complete blast clearance from peripheral blood is superior to predicting that there is no risk of relapse. They also have shown that Wilms tumor volume is a predictor for relapse. Tumor volume of less than 270 ml after chemotherapy, event-free survival is 90% as opposed to 57% if your tumor volume is larger. And below is this very elegant RCT on the difference between palnocetrone and ondansetron. Palnocetrone given once in 48 hours actually reduces the workload and reduces the cost of therapy, as opposed to ondansetron, which you need to give during, throughout the first few days. And then, of course, who can forget COVID-19? This is the effect of COVID-19 on cancer chemotherapy. A third of patients needed modification in treatment, and there was a delay of nearly a month as a lot of them were still shedding COVID virus. All have recovered completely, and this needs to be compared with a non-COVID cohort. Nephrology actually has actually involved with establishing guidelines for hemolytic uremic syndrome and steroid sensitive nephrotic syndrome. In India, they do RCTs on TAC versus cyclophosphamide. And this is actually an RCT on rituximab versus tacrolimus in difficult to treat steroid sensitive nephrotic syndrome. You can actually see that sustained remission, red rituximab is equal to that of the blue tacrolimus, but when it comes to relapses, those treated with rituximab had more frequent, significantly higher number of relapses, so it was not non-inferior to TAC. Rheumatology, as we heard mentioned, has the highest cohort of pediatric rheumatic diseases in the country. GIA, SLE, Takayasu, they do a lot of work on treatment for SLE, and they have the largest cohort of Takayasu arthritis in children in the country. Their articles talk about angiographically derived classification system, comparison between childhood onset versus adult onset disease, treatment with combined immunosuppressants, tocilizumab, and outcomes of percutaneous intervention. So this is actually the percutaneous intervention that you do with Takayasu is stenting, balloon angioplasty, and this is actually the snapshot from the article. You can see that out of more than 1,000 Takayasu arthritis, 942, the vast majority are treated with percutaneous intervention. And of the 942, 171 were children below the age of 18, and with very good results on 15-year follow-up. So this is an ICMR study being done in the ICU, being analyzed on differences in fluid management in children with dengue, comparing WHO and a CMC fluid plan. And this is something that has come up, remote training of simulation and telecommunication and simulation. So this actually, you have, if you look at the red box on the bottom, there is a facilitator at one end who will, feed videos to, remote locations, and additional facilitators can be used elsewhere to assess what is going on, and remote learners, what does this actually do? It actually improves real patient pediatric shock outcomes in the emergency. So what you find is that, the achievement of a score is much higher, and, the time to resolution of shock is much lower, and development of MODS is also much lower. So this telesimulation has actually made a difference to outcomes of shock in India. Neonatology has three major domains: sepsis, asphyxia, and nutrition. They have been able to show that fortification of human milk with infant formula as opposed to unfortified milk has actually better outcomes in very low birth weight infants. And then, of course, neurodevelopmental outcomes after group B streptococcal infection. What they actually have been able to show is that neurodevelopmental impairment is much more common with group B streptococcal infection in more than one domain, and this actually tells you that one does need a group B streptococcal vaccine. And then neonatology is also pioneers in therapeutic hypothermia. You heard Anil talk about this Miracradle, which is a convection mattress with phase contrast material used for cooling in hypoxic ischemic encephalopathy. We were the first unit to start this. This has won the Scotch Award, the WHO Award, and is now used widely in India, Africa, and has been included in the WHO Compendium of Innovations for Low Resource Settings. Developmental pediatrics, as mentioned, has two birth cohorts. What they have actually found with these birth cohorts is that stunting and can give rise to cognitive issues, basically because of smaller corpus callosum and cerebellar cortices. And so they've also been able to show that what makes a difference in this is an interactive home environment and structured preschool education. They also do an autism study with MRIs, ICMR funded, comparing autistic spectrum disorder and normally developing children. And what they have found is children with autistic spectrum disorder have smaller corpus callosum and the language areas are also smaller. Now, how does this change practice? What means is you cannot manage with just verbal communication. You need to have multisensory communication, including visual, tactile, and object-based. Pediatric pulmonary services, actually, you heard Dr. Raghupathy talk about the very first cystic fibrosis case in South India. The dots on the map are where the, right now cystic fibrosis education is going on. This is all over the country. There is plan to set up a CF registry, CFTR gene carrier frequency, and then, the contribution of that to mortality and mutations, all these are publications from the department. Pediatric gastroenterology has been able to show that pancreatic insufficiency is the most common GI manifestation, and some of the other things that pediatric gastroenterology does for research is whole exome sequencing in inflammatory bowel disease, which may reveal targets for potential specific therapy. And this is a recent publication. I tell you, the number of stories any of our departments can tell is amazing. Looking for causes of cystic fibrosis, they discovered a rare variant in those dots over there, 4 cases in Vellore and Tiruvannamalai, which have only previously been described in France. So how does this happen? So that map is actually a 17th century trade map from India, Pondicherry. Second point of call is there are the French Réunion Islands off the coast of Madagascar, around the Cape of Good Hope. Next is Senegal, next is France. So it is quite likely that indentured laborers from Tamil Nadu actually carried this to the Réunion Islands, and the first time that this was documented is in France, and now we know it comes from here. Okay, adolescent medicine actually does a lot of work on substance use, sleep disorders, depression, eating disorders. We are the first medical college to make and disseminate a protocol for management of child sexual abuse, and plus the concepts of what is good touch and bad touch. So these protocols have been published and are being disseminated. ID, a few things that have been done. SCAR in pediatric scrub typhus, we know we need to actually look in areas which you would normally not examine, to look for an SCAR, because those are the commonest areas. And if you look at that, you find that nearly half of children will have an SCAR. We are also part of a rapid TB group for looking at newer diagnostics in tuberculosis. With 4 African sites, we are the one Indian site. And so what we have actually looked at is gene expression of Mycobacterium tuberculosis. We've actually been able to prove that upregulated and downregulated genes can be assessed to look for tuberculosis, and in combination with the expert you can pick up more than 70% of confirmed tuberculosis. The Well Baby Clinic, as already mentioned, established by Dr. Jacob John and Dr. Raghupathy. Now, Hib vaccine came in 1997 and pneumococcal vaccine only in 2006. So as Dr. Jacob John says, this is actually one of the only documentations that Hib vaccine makes a difference to Hib disease. The green line is Hib vaccine doses starting in 97, steady state after 2001. The red line is the fall in Haemophilus influenzae meningitis, and pneumococcal meningitis is unchanged. Following this up in multi-site surveillance, Hib disease after this was 74% lower than other centers in Chennai, Lucknow, and New Delhi, where Hib vaccination had not yet come into the community. The other thing that has actually changed our management for guidelines is actually pneumococcal infection resistance patterns, and this is from 2008 up to 2016. You can see that penicillin resistance, which is the blue line, has increased from 10% to 40%. Cefotaxime resistance, surprisingly, has increased up to nearly 30%. So now we have empiric antibiotic therapy for meningitis is to add on vancomycin as well. Coming to the last few slides, COVID vaccine. These are actually two studies done on the immunogenicity and safety of homologous and heterologous boosting. And what was found is that, if you give a boost with Covishield after anything, it is actually the best outcomes as far as immunogenicity is concerned. And not to forget HPV vaccine. HPV vaccine, almost the very first studies on HPV vaccine in boys and girls, the recruitment was done with Dr. Rajiv in our Well Baby Clinic. And this is actually for the Serum Institute vaccine in comparison with the quadrivalent Gardasil, and it was non-inferior. Thank you, and I will stop there.